nonpartisan fashion in the past. These issues are important to everybody, not just Democrats or Republicans. So I hope we can continue to work that way. We've tried to be somewhat ambitious with the way we approach the topic, and we've had some success. We've had some failure. We've got to get through this pandemic. We've got to get through this money issue because a bunch of money's on hold right now. I want to welcome Sia Price and Monty Mason and Mark Sickles once he joins. Yeah, there he is. Hey, Mark, our new members. You'll find that this is a good group to work, and we expect all the members to participate as much as they can. And as I said, we're going to participate in a nonpartisan fashion. What I'd like to do, unless anybody else has anything to say, I'd like to go ahead and get started with Sarah. Does anybody have anything? Hey, George, good to see you. Okay, Sarah, if you want to kick off with the overview, I'd appreciate it.
Hello, everybody. I'm going to walk you quickly through the overview and purpose, scope, history of the Joint Subcommittee, and I can give you some information about the outcome on our recommendations. This information is available to you. I sent you the table, and we'll post it on the study website after the meeting as well. Very quickly, just some background. Subcommittee. The Joint Subcommittee was created in 2014 with Senate Joint Resolution 47. The purpose of the Joint Subcommittee was to review and coordinate the work of the Governor's Task Force on improving mental health services and crisis response, reviewing the laws of the Commonwealth governing the provision of mental health services, assessing the system of publicly funded mental health services, including emergency, forensic, and long-term mental health care and services provided by local and regional jails and juvenile correction facilities, identifying gaps in services and the types of facilities and services needed to meet the needs of the Commonwealth in the 21st century, and recommending statutory or regulatory changes to improve access to services, quality, and outcomes. The Joint Subcommittee was initially established for 4 years. We were extended one time in the 2017 Appropriation Act. That was a 2-year extension, and then extended once again during the 2019 regular session. Senate Joint Resolution 301 approved the Joint Subcommittee through the end of this year. So we are supposed to finish our work by November 30th of this year.
And if I could just, I don't know, Sarah's done an awful lot of work to get ready for this meeting and send out a lot of materials. I know my printer went just about dead trying to print all this stuff. So you all should have everything she's working from. You probably also got email from Delegate down in Henrico County. What's his name?
It's Delegate Van Valkenburg.
Okay, Van Valkenburg. He suggests that we include citizen members. There have been a whole lot of commissions that have looked at mental health in the past, and a lot of them have included citizen members, but there are a lot of recommendations that sit on the shelf. The reason why we have been exclusively, the membership has been exclusively legislators, my hope is that we all take ownership of the results of each year's work and work to get the bills passed, not just put them on the shelf. We can certainly include citizens in work groups and try to get their input, and we try to do that as much as possible. I'm sorry for interrupting, Sarah. I just felt the need to jump in.
Of course, sir. I'll move very briefly through the rest of what I have. As Senator Deeds said, this was all distributed to you before the meeting, and it will be available on the study website for the public and for any of you who need to follow up with the materials. Throughout its history, the Joint Subcommittee has met pretty consistently. We've had a series of full Joint Subcommittee meetings, and there have been different work groups over the years. You can find information on the work that the Joint Subcommittee has done on the study website. There are meeting summaries there, as well as copies of the annual executive summaries. Those can also be found on LIS. I've included in your materials the 2019 executive summary, and that should also be available on LIS. If it's not, it will be shortly. So you can refer to that if you have any questions about what we've done in the past years. I'm also always happy to talk offline about sort of some of the areas of focus and things we've worked on. I've distributed to you the 2019 recommendations and then the outcomes of those recommendations. That also will be available on the website for the public. I can walk you through those now if you'd like. There were some legislative recommendations as well as budget. I think Mike will touch on a lot of the budget pieces as he talks through.
And I think it would be a good idea to walk through that, Sarah. Thanks.
Certainly, I'll do that. I'll try to go quickly in the interest of time. Looking at the legislative recommendations, the Joint Subcommittee had a number of recommendations last year. I'll walk through these, give you the bill numbers and some outcomes. The first recommendation was that the General Assembly should amend statutory provisions for involuntary temporary detention of individuals in need of medical services to include intoxicated individuals. This was a recommendation. It's not the 37-2, 808, 809 process that we often focus on. This is the medical TDO to allow for testing and observation in certain situations. Senator Deeds carried Senate Bill 738 and Delegate Hope had House Bill 1452 that would have implemented this recommendation. Those bills were adopted by the General Assembly and signed by the governor. One piece to be aware of is that the bill directed the Department of Behavioral Health and Developmental Services to convene a work group to develop standards and policies and procedures regarding the medical temporary detention orders. The agency has started meetings on this. They're working on it throughout the summer, and we will get some updates on their conclusions and their work. Moving forward to the next piece where we had legislation, the Joint Subcommittee recommended that the General Assembly should improve the evaluation process to facilitate quicker access to services by expanding the categories of individuals who may conduct an evaluation pursuant to 37.2-808. Delegate Watts carried this bill. It was House Bill 1351. As introduced, the bill would have expanded the category of individuals who could conduct the evaluations to include any person described in the definition of mental health professional in 54.1, 2400.1, who is skilled in the diagnosis and treatment of mental illness, has completed a certification program approved by the Department of Behavioral Health and Developmental Services, and complies with regulations of the Board of Behavioral Health and Developmental Services related to the performance of such evaluations. This bill was continued to 2021 by voice vote and has been referred to this Joint Subcommittee for further, it's been referred to DBHDS for further study during the 2020 interim. Again, they've started working on this already and have some meetings underway, so we will get an update on that in the future. The Joint Subcommittee recommended that the General Assembly should enhance data collection around the bed registry. It would include mandating reporting of daily bed utilization, revising the bed registry to allow for better data collection and monitoring of the emergency custody process, and leveraging emergency department care coordination technology to improve care for individuals with psychiatric needs through better linkages and coordination. Senator Deeds carried Senate Bill 739 and Delegate Hope had House Bill 1453 that directed the Department of Behavioral Health, in its final form, directed the Department of Behavioral Health to establish a work group to evaluate the role of and make recommendations relating to improving the structure and effectiveness of the psychiatric bed registry in collecting and disseminating information about the availability of beds in the Commonwealth. Again, that work is underway and we will get an update on that in the future. The Joint Subcommittee also recommended that the General Assembly should amend the Code of Virginia to establish the obligation of healthcare providers who have been notified that an individual to whom they have provided services is incarcerated to disclose to the jail any information necessary and appropriate for the continuation of care and to provide legal protections for those healthcare providers. Senator Hanger had Senate Bill 748. That bill was incorporated into Senator Boysko's SB 656, and Delegate Watts had House Bill 1328 that implemented this recommendation. They were all signed by the governor. From there, we move into a series of bills that dealt with mandatory outpatient treatment. These are all Delegate Hope's bills. I will move through them pretty quickly. If you have any questions, please let me know. On the general topic of mandatory outpatient treatment, we had recommendations suggesting that the General Assembly should increase the length of the initial order for mandatory outpatient treatment from 90 to 180 days. Authorize a judge or special justice to convene a status conference to review compliance with the order. Eliminate the requirement that the person who will be subject to the order agree to the proposed outpatient treatment plan prior to discharge. Provide that community services boards petition the court for enforcement of an order must allege that the noncompliance occurred despite efforts of the CSB to assist the person. The Joint Subcommittee also recommended that the General Assembly should clarify the scope of the examination that can be ordered by the court when a petition for review of a mandatory outpatient treatment order is filed, should provide that the criteria used by the court to determine whether to continue, alter, rescind, or extend a mandatory outpatient treatment order are the same as those used by the court to determine whether to issue the initial order. And finally, to clarify that a mandatory outpatient treatment order remains in force until it is rescinded by the court or expires, even if the person revokes their agreement to abide by the order. These various recommendations were included in House Bills 699, 700, 702, and 713. Again, they were Delegate Hope's bills. All of these bills were continued to 2021 or tabled in the relevant committees and referred to the Joint Subcommittee for study this summer. So they will be on our work plan moving forward. Moving from there, we had two recommendations related to alternative transportation. The first would have allowed a magistrate to change the designated alternative transportation provider at any time until such time as the transportation actually begins. The second recommendation would have allowed a law enforcement officer in a jurisdiction in which an alternative transportation provider becomes unable to continue to provide transportation to take custody of the person and continue transportation themselves. Senator Hanger had Senate Bills 602 and 603, and Delegate Bell had House Bills 1117 and 1118 that would have implemented these recommendations. Senate Bill 602 was rolled into Senate Bill 603. House Bill 1117 was rolled into House Bill 1118. Those two bills, 603 and 1118, were adopted by the General Assembly and signed by the governor. The final legislative recommendation was a recommendation to the General Assembly adopt the interjurisdictional compact on psychology. Senator Deeds carried Senate Bill 760, which was adopted by the General Assembly and signed by the governor. I'm going to hold off on the budget recommendations because I think Mike may be able to talk more thoroughly about those than I will. So at that point, I'm happy to answer any questions you may have.
Okay, are there any questions for Sarah? But next, we're going to hear from Mike on the status of funding because there's a significant chunk of change that was unallotted for behavioral health. And that couldn't be avoided, I don't guess, but we're going to find out about it. Mike, good to see you.
Thank you, Mr. Chairman. Good to see you too, Senator Deeds. Let me share my screen. Okay, good afternoon, and thank you, Mr. Chairman and members of the Joint Subcommittee. It's good to be with you all this afternoon. My name is Mike Tweedy. I'm staff to the Senate Finance and Appropriations Committee for the Health and Human Resources area. And this afternoon, I'm just going to give you kind of a high-level overview of the 2020 session and the funding actions related to mental health and behavioral health services and the status of that funding, like Senator Deeds mentioned, related to the unallotments. So just a high-level overview in HHR, basically there was a net increase of $1.2 billion over the prior two-year budget. Typically, the major funding actions include fully funding Medicaid and other mandatory programs. That's pretty typical. That the majority of funding is to fund those entitlement and other mandatory programs. However, there were other significant investments made in other areas. So, for example, a variety of Medicaid provider rates were increased in total to about $170 million general fund over the biennium. And then in the area of community behavioral health funding, that was increased by about $155 million, so a very significant investment. However, as you all know, the COVID-19 public health crisis has led to a potential impact in our budget that is still being fully assessed. As you recall from the reconvened session back in April, the governor sent down amendments to unallot roughly just over $2 billion over the two-year budget, and $442 million of that was in the health and human resources area. So as Senator Deeds said at the beginning, he talked about it being on hold. That's the best way to explain what unallotment means. It's not a term that we typically use on the legislative side because allotments have to do more with, it's like an executive thing. But simply what it means is the appropriation was not changed. It's simply in a status for which it cannot be expended by the agency. So it's essentially on hold. And the way the language was drafted by the governor that he had sent down that was adopted essentially says that once we act upon the new revenue forecast in the next, which will be the special session in beginning this month, essentially if the appropriations are reenacted by the General Assembly, then it can proceed. But it does require action by the General Assembly to kind of move these things from a hold status to move them forward. And that's all going to be dependent on how much funding is available to reallot some of that funding. But just to note, out of that the 155 million I kind of mentioned for in total for community behavioral health, about 135 million was unallotted. And this next screen, you can see kind of how I get to that number. This covers most of the behavioral funding. There are a few other things that are out there, but you can see the major one is STEP Virginia to continue implementation of that, which is began back in the 2017 session to provide the continuum of services across all CSBs. I have the next slide will actually go into more detail about STEP Virginia, but all of that additional funding was unallotted. The next one, permanent supportive housing, that was 25.5 million. This would have actually doubled the annual appropriation for permanent supportive housing by the second year of the biennium. So it was a major investment in that evidence-based service. Discharge assistance planning, those are the funds that we use to transition individuals from state hospitals to support them in the community. That was the $20 million provided for that. That was a significant investment too related to the census pressure in state hospitals, which the next one for 15 million was also related to that. That was kind of new funding added for pilot projects that the department would engage with private hospitals to divert some of the individuals so they wouldn't be sent to state hospitals to help reduce census pressure. But again, that was another item that was unallotted. The next one, increasing options for inpatient services for children of 14.7 million. This one remained allotted and available for spending. And the rationale behind that was that the pressure on the children's, the Commonwealth Center for Children and Adolescents in Stanton was the most serious issue at the time. And so that funding was left available. And if you recall in the FY20 budget, the caboose budget that was passed, there was language to have for a work group to look into that. And they reported back in June how they think the money should be used and what's needed to kind of relieve the pressure there. The next one, the 8.4 million, the Virginia Mental Health Access Program. This was started in the 2019 session. This funding would have expanded it statewide. Basically what it does is it gives greater access to pediatricians, training and access to mental health professionals to help treat and provide mental health care to children in the primary care setting, which is oftentimes where children are most likely to appear. Then you can see 5 million for the mandatory Part C early intervention services. This is a mandatory service, which is why it remained allotted and available for appropriation. And then lastly on this slide is the forensic discharge planning in jail. In the 2019 session, funding was added for this one. And this would have actually increased it from 2 to a total of 5 jails where we would be discharge assistance for individuals with mental illness into the community. So out of that 155 million, you can see the 2 items that remain allotted, but the vast majority of it is in that kind of hold status. The next slide just gives you the STEP Virginia funding status. So what it shows you is by service, and you can see the first column in the middle, the base funding 2020 to 22 biennial amount. That's the 2-year kind of base amount that was that comes forward from the previous budget. So there are 2-year numbers. So same day access is 21.6 million is in this biennial budget to cover the cost of those services, and then you can see the primary care screening, crisis, and outpatient below that. So there was already 78.3 million kind of in the base funding, which is almost 40 million in general fund per year. The column to the right of that, the 2020 session funding added is that was added in this past session. You can see additional funding was provided for crisis services, outpatient services, the peer and family support services, military and veteran services, There was 6.4 million added for CSP support staff. That's not a service in and of itself. That was just a recognition that STEP Virginia is a whole new way that CSBs have to operationalize how they work. So it was addressing some of their administrative and operational issues. And then there was 1.4 million of funding for administration at the central office at DBHTS to kind of oversee the whole STEP Virginia program. But like I already said, all 54 million of that in STEP Virginia is unallotted and thus on hold. Other behavioral health funding actions that I'll just touch on. Kind of the other major, and this is a community-based service too, the Medicaid redesign that I think Dr. Ward will go through with you later. This was increasing rates and adding new services to the community rehabilitative services in Medicaid. And there was a little bit of funding in there for provider training. That funding was unallotted. There was an increase in Medicaid for mental health professionals, their rates to 110% of Medicare. We'd increased that to 100% of Medicare in the 2019 session. This was just further recognition that it's to increase those rates to try to encourage more people to enter the workforce in mental health. And that's in addition to the next one, the Behavioral Health Loan Repayment Program in the Department of Health for 3.4 million. That was a new program based upon a study that General Assembly had directed back in 2016 to look at. We already had loan repayment programs for physicians and nurses, and this was the idea in the behavioral health world. And they put together a stakeholder group that recommended a program that finally in the 2020 session was funded. So again, this gets at the issue of the workforce issue that I know the Joint Subcommittee has talked a lot about in recent years, that it's great, you can fund a lot of services, but you have to have the people to provide the services too, and that workforce component is very important. Lastly, I know there's just about 300,000, which was kind of kickstart transportation of state hospitals after commitment. This is something I know the Joint Subcommittee has discussed in recent years. It's kind of an issue which alternative transportation, which has been funded. That's an alternative for law enforcement to take people to state facilities under a temporary detention order. But there is an issue sometimes for individuals that when they're taken to a state hospital far from home, that they may not have the family support to get them back to their home. And oftentimes the CSBs have to figure out a way to get it done. And so this was an idea to look at that model to see if we couldn't transport people from state hospitals back to their home when their TDO commitment is over. The bottom part of this chart just shows you for the behavioral health facility side. The largest amount of funding is 5.9 million. This is for the Virginia Center for Behavioral Rehabilitation, which is related, that's the sexually violent predator program. This is related to the expansion, the additional 72 beds that will be fully operational by the end of this, in the second year of this biennium. You'll see 5.4 million and the 1.9 and 1.5, the next three items are all related to state hospital security staff, pharmacy costs, and clinical staff at the Commonwealth Center for Children and Adolescents. That's all related primarily to the increased census levels at the hospitals and dealing with the issues that come with higher census issues. And the last item you'll see is about 700,000 for supervision of conditional releases from the Virginia Center for Behavioral Rehabilitation. That is the only item on this page that remained allotted, but that's because when they're conditionally released, the department pays the Department of Corrections to supervise that conditional release. So it's kind of a required action. So this last slide, I'll just talk about just some of the budget language that's related to mental health and behavioral health. There's always quite a bit. These are some of the more major ones. There was language directing a review of Medicaid peer recovery services to look at what impediments there are, to see if any regulations could be amended to kind of increase access to peer recovery. There's language to develop a plan to pursue mental health services waiver. So this is a new federal waiver that once a state has a more robust system of community-based services, then they can apply for this waiver. And the waiver will actually allow states to kind of access federal funding for the operation of the state hospitals, which traditionally have always been funded by just state funds only. So this is a language that has the agencies developing a plan to kind of keep us on that course to try to pursue that waiver in the future. There's also language related to the crisis intervention team assessment centers. basically directing the agencies to look at how to move more toward a 24-hour, 7-day operation so that they could serve more individuals and move them also more toward regional sites as well. And lastly, I'll point out here, Children's Hospital of the King's Daughters has begun construction of a new 60-bed mental health hospital. And there's language kind of directing the department to work with them to see if, and it potentially could be some type of financial commitment by the Commonwealth at some point in the future, but to look at a partnership with them to help provide treatment services to children to kind of avoid admissions to the Commonwealth Center for Children and Adolescents and help reduce pressure there. It's not on the slide, but I will just kind of go back and say, if you recall, in the original governor's budget, he had proposed funding related to expanding Catawba Hospital, which is something the General Assembly rejected, and there was language put in to basically by the end of this fiscal year to move them back down to the 110 beds that they previously were at. And there was a report on how they were going to do that required that was also submitted in June. So with that, Mr. Chairman, I mean, I will just say that a wide variety of these items are things that the Joint Subcommittee has supported, both from this in this past session and past years. So but that kind of gives you the main overview. So unless there are any questions.
Thanks, Mike. Are there any questions for Mike?
This is Delegate Price.
Delegate Price.
Thank you. I just had a question because I just wanted to know if this conversation has happened before or if this is kind of uncharted territory. But it seems like everything's connected, well thought out, but we don't have the money that we had when we passed all of these things. So is there a method that we go through in order to prioritize? Because we definitely want to protect vulnerable populations during the pandemic, but I didn't know if there was like a set method or metric that, or algorithm or whatever, in order to see what some of the priorities would be.
I don't think we've had that conversation yet, or at least I've not been involved in it. That's definitely something we need to be thinking about in terms of priorities. Which of your children are you willing to give up? That's essentially what we have to do when we're deciding the budget, because we did very well in this past budget. So which of our children can we live without? That's essentially what we have to decide. I would say to Senator Barker and Senator Howell and Senator Hanger and Delegate Rush, Delegate Sickles, so many people that are on the money committees. That's what we're looking at. Which of our children can we give up? And each one of these things is going to improve somebody's life. That's what makes it tough. I don't know if we want to have that conversation now or we want to wait until we have more time. But we're certainly going to have it we're going to have that conversation probably at the latest the week of the 18th, I would think.
And Mr. Chairman, this is Mike Tweed again. I'll just add to, I think you also see to Delegate Price's point, when DBHDS presents next, you'll kind of get an idea of what is the current status of things with the state hospitals. They'll share with you kind of things improved a little bit, but now they're not so great. So some of those most urgent issues will certainly rise to the forefront, but we're still in the process as we get closer to the special session and the governor sends down his version of the budget. We'll have to look at just the revenue situation and how much money is available.
It seems to me that Commissioner Land's presentation and Dr. Ward's presentation after that may well influence what our priorities are. So what I would suggest is that sometime the week of the 18th, when we are all back together, that we form we get kind of a rump group together to figure out what our priorities are going to be, or if we're just each person for themselves. We've got to figure out whether we're going to pursue particular priorities in the special session. Okay, if there are additional questions or comments,
Corey, it's Janet.
Madam Chair.
Thanks. I just wanted to weigh in that from my perspective, the human services and education and healthcare are the most pressing needs we're going to have and where we're going to have to focus with the unallotments. But also, this is going to be really austere. We are not going to have the kind of monies that the press seems to be saying that we are. The governor will be announcing his revenue forecast, I think by the end of the week, certainly by the beginning of next week. And it isn't going to be good. It's not going to be good. So we have to really struggle with these priorities. I think C is right.
It's going to be tough. Yeah, that's
sorry.
That's a tough set of circumstances to work in. But Commissioner Land, if you'd like to make your presentation, I'd appreciate it.
Mr. Chairman.
Senator Mason, was that?
No,
Delegate
hey, this
Sickle?
is Jennifer Rush.
Okay, I'm sorry. Delegate Rush.
Hey, sorry, I may have missed this, but did we mention the CARES Act, and have we tried to find funding where we've had excess cost in the system throughout COVID-19 pandemic, and whether we're able to do that or not?
I don't know if Mike can address that. I expect Commissioner Land is going to have something about that in her presentation.
Yeah, Mr.
Okay, that's great. Thanks.
Yeah, this is Mike Tweedy. I'll just add that, yes, I mean, we have, the administration has been good with sharing what they've been doing with the CARES Act, and certainly, you know, a lot of that funding will be going into the world, into the HHR world as well. So, but that might be one of the questions when we get to the special session to see ultimately how the administration has decided to spend it. As you can imagine, there are been a tremendous number of requests for that money, even though it was, you know, $3.1 billion to the state. The requests, I think, far exceeded that.
Sobering. Delegate, our Commissioner Land, we appreciate you being here.
Thank you, Mr. Chairman and members of the Joint Subcommittee for inviting me to speak with you today. Next slide, Heidi. I've got a helper doing my slides with me. The presentation is going to focus on the census crisis and COVID-19, which, along with the DOJ settlement agreement, are the highest priority items for DBHDS and what we're managing today. We'll also be providing an update on the post-2020 session activity. Sarah shared some of those work groups, and we'll give you some updates on those towards the end of the presentation. So, at first, we're going to talk about the state hospital census, and it really did decrease during the height of COVID-19, so for those first 3 months. But as we've moved to reopen, the rising census over the past 4 weeks has reached a crisis level. And as you can see on the slide that you're looking at now, this is the trend since FY 2015. And we've done projected for 2020 because we don't have from the magistrates all the TDO numbers. We have the ones that came to the state hospital. So as soon as we get those, we'll update the slide and share that with you. But you can see that state hospitals, the increase is about 1,500 additional individuals per year. We've had about the same number, so it's been fairly level around 25,000, yet the state hospitals are getting the increase. And then also just to share with you that about 81% of those are civil TDOs. Where we're seeing our most pressure is in our geriatric beds, and our ability to quarantine and isolate is greatly reduced right now, which is why I stopped admissions to Piedmont Geriatric Hospital on July 14th when it experienced an outbreak. It was just unsafe. I had to do that. We also put a hold on the Southern Virginia Mental Health Institute because of an outbreak there. They really have a unique layout, and they need all of the flexible space they have to isolate the positive cases and protect their patients, all the other patients and staff. We also have admission holds. Those were only done after taking into consideration the recommendations from VDH, and we're really working closely with them so that we can carefully reopen once it's safe, and we'll do that as soon as we can. Okay, so I had mentioned that during the first part of the pandemic that we really saw a reduction. You'll see on this slide, you can see in those March, April, May months just how far our volumes were down. So 23%, 46%, 22%. But then in June, when we started getting that phase 3 reopening, they have just gone way up. And we're actually anticipating that the July final numbers are going to be over 800 admissions. So you can see exactly what we're facing. Some of the reduction that we achieved in those first months was due to aggressive census reduction procedures, including discharge planning, really partnering well with our CSBs, and also reducing the number of patients on the extreme barriers list. The stay-in-place order also helped hold that down, and we saw fewer crisis evaluations in April than any month in recent memory. The geriatric beds, of course, remained full because those individuals are much harder to place in the community. So we typically see an uptick at the beginning of summer. That's very typical for us, but the reopening has really led to this severe census crisis. The next couple of slides, we'll look into the special population. So we're going to start on this slide with the geriatric beds, and you'll see that geriatric admissions have increased, even accounting in FY 2020 for the temporary drop that we experienced in April. We have, so everybody knows, we have geriatric beds at 4 hospitals. Piedmont Geriatric Hospital is all geriatric. We do have units at Eastern State, Catawba, and Southwestern Virginia Mental Health Institute. But even before the admissions hold, the geriatric units were at or over census all across the state. And what happens when we're over census on those units is that we have to look for bed availability in the adult units, which then reduces our capacity to handle the adult PDOs. We're constantly, of course, the staff in the hospitals are adapting and using any available space and moving around staff to have to accommodate admissions. So we have currently 23 patients and seven staff members at PGH are currently positive. And unfortunately, sadly, we've had 6 deaths at Piedmont since the crisis began. And they're going to be on hold at Piedmont until further notice. And we'll be diverting patients as beds become available in other state hospitals. On this next slide, we're going to look at CCCA, our child and adolescent facility. Its trends are very concerning as well. We've seen this decrease in FY 2020 due to the drop in the census levels, because when we typically see, and I know y'all are probably very familiar, or most of you are, that when the children are out of school, so in the summertime, we typically see a drop in the census. So we're seeing a drop much earlier once the children went home and the schools closed. And so we saw a huge reduction there. But you can see that if we had not had that, we would have exceeded even 2019, which was a huge jump for us. So that's we're going to have to be watching that really closely as changes occur, because as it rises, the census there, it becomes more difficult to maintain a safe and therapeutic environment for the children. And we see increased overtime, injuries, and a lot of staff turnover typically. So this is a real area of focus that we need to keep our eyes on. This is a picture as of yesterday of what the actual census that we're experiencing in these facilities are. So that's the current utilization rates and breakouts based on not just the total, but looking at geriatric versus adult utilization. And you'll notice that when it's over 100%, it's in red. And you can see there too the Piedmont and the Southern Virginia that are on hold. We are actually being required to isolate the entire facility at Southern Virginia for at least 28 days, and that's from the last positive case that comes into the facility or is identified in the facility. So that can, if we have another positive, it can extend it another, the 28 days restart. So far, we've been able to divert admissions to other hospitals and safely discharge individuals who tested negative, but it's been quite a task for the state facilities. And then we also have units at Eastern State and Western State that are under quarantine. So some of those units, the adult admission units, and so they have reduced capacity. So when you see that they're over capacity, we're really, really over capacity. So for example, Eastern State's admission unit has 23 beds, but only 12 beds are able to be open because of the quarantine. And Western State's admission unit has 28 beds, but only 5 beds are able to be open because of the quarantine that's going on there in those units.
And Commissioner Land, excuse me,
Yes.
When you're over 85% capacity, you're really over capacity, aren't you?
Yeah, it gets really unsafe. We were looking at the staffing, and we're at 78% of staffing. We don't staff to 100%. We staff and budget staff at 90%, but we're currently running at 78. So it's really the staffing shortage is huge. The vacancies are huge, but then on top of it, go up to 100, 105, 115%. That just impacts it even worse. So it becomes really unsafe. So on this next one, I wanted to kind of go through. I know I've talked to several of y'all on the phone and have shared some of what we've done in our facilities in response to COVID, but some of the actions were we originally just immediately visitation restrictions were put in place. Aggressive plans for infection control and isolation of both presumed positive and positive cases, so those that were exposed, as well as, and we were waiting for results, as well as those that were positive. We are continuing to collaborate and problem solve with all of the section chiefs on the Emergency Operations Center, give them all kinds of guidance around diversion, being able to divert at 105% of maximum census or 75% of critical staffing levels. And our census was at that crisis level before the admission holds at Piedmont and Southern Virginia. I've currently given operational guidance to deny admission of all positive patients because we have to maintain the viability of our units and not have an outbreak and have to close any more facilities. Our PPE resources are being tracked and are starting to stabilize, although in the non-quarantine and isolation units, excuse me, we are still doing contingency PPE usage. And we've started doing crisis standards of care planning so that we can be prepared with some system-wide guidance in the very near future if this crisis continues or worsens. Wanted to share a little bit about the COVID-19 expenses that the facilities have been having. And so what you'll see is for each of the facilities, what their expenses were as of June 30th, at the end of the fiscal year for personnel, supplies, and equipment, and then a total. 5 of our facilities are Medicaid certified and designated rural, so they were eligible for the provider relief funds or the rural provider relief funds. And so you can see that those have received those amounts there. There are still unmet needs, and those other facilities, not the 5, have not received funding, and these facilities have not received any CARES Act funding yet either. We have worked extremely hard on the extraordinary barriers list patients. And for everyone, I think that you're probably very familiar that anyone who's been ready for discharge for 14 days, but for whom there's a significant barrier preventing a safe discharge, goes on this list. And you can see on this slide kind of how the monthly volume has gone, and then kind of what our barriers typically are. This is an example of ones that are either waiting for discharge, their discharge is scheduled, if it's a guardian barrier, if we can't find a willing provider to accept the discharge into their facility. And it's been rising in recent years. So in February, before the pandemic, you can see there that we were at 237 patients that were on this. more patients than in 6 of our 9 state hospitals. The entire bed count, 6 of our 9 has less than that number of patients that they can manage. So it's at least a whole facility on the EBL. Over the past 4 months, we began an EBL group. The average number of discharges per month has been 74, as compared with the previous year. The same time period was 62. And in July, EBL discharges were 94. So we're really getting some traction and finding ways, creative ways to get folks discharged out of the facilities.
Commissioner Land, we've been at this for a while, and this is the most detail we've ever had on the extraordinary barriers list. Thank you so much for this.
Oh, you're welcome. This is one of my I have an intense focus on this because I feel like it's so unfair during this pandemic that our staff are so short and we have such a high census and they're still having to manage, 200 patients 24/7 that have been ready to discharge. They're ready to go. So they don't need to be there. And this is just, how do we put that much extra work on them? So I'm really focused on this. We've also been working down the average length of stay for these folks. So in previous years, it was around 86 days, and now we're down to 78 days. We actually, in May, were successful in discharging the individual with the longest tenure on the list, who had been there on the list for 1,148 days, which is, so that was a tough one, but we were able to do it. So we are targeting these barriers. So we're trying to get action plans for each of these barriers. So just as an example, we just issued an RFP for guardianship and conservatorship services for individuals. That's one of those main barriers on there. And we've entered into Exhibit Ds to the performance contract with 3 CSB crisis stabilization units in order to have those for step down from the state hospitals as transition, as we're waiting maybe for permanent supportive housing or a group home or that type of thing. So we're really trying to increase the throughput there and find innovative solutions. So here again are some of the successes. So we've had 329 individuals discharged from the EBL since we started our new work group on April 1st. That number we had, it'll be different than maybe one of the original slide decks that we sent, because I noticed that when I was reviewing and practicing, I was like, oh, that number hasn't been updated. And so I wanted to make sure to really point out just how much work we've been doing. But of course, we've got this huge influx of patients, so they keep populating back onto the EBL as they're ready for discharge. So I went through some of these numbers about the number and the average length of stay. So those, but then some of the continuing challenges are the continued restrictions on nursing home and ALF admissions that are really hampering our ability to discharge. We also have limitations on some of the CSB services, which is impacting the CSB's ability to complete certain discharge planning tasks, which of course put a lot more strain on the workload of the hospital social workers, but we're still making progress. And then we're working with the CSB leadership regarding strategies to continue to use DAP for new state hospital discharges in FY22. There's a lack of DAP funding that may impact the EBL discharges, and so we're working on different strategies for that, but we still have a concern, of course. So you can see on this slide, these are those just continuing strategies that we're focusing on in these main buckets to address the census. And we're actually just engaging every strategy that we can. And I know that y'all are aware that it involves managing both the front door in terms of diversions and the back door in terms of discharges. And so working on any strategy that we can to make things better with the census. Wanted to share on this next slide some of the new agreements, some of the older and some of the newer agreements, but we've actually reconfirmed the existing agreements and also developed 3 new agreements since December to address the census. I do want to point out the highlighted rows. Those are the new contracts that we've had. One with Commonwealth Senior Living, which has ALF services, and we had about 79 patients that needed to be discharged on the EBL to an assisted living, and we've been very successful. They are accepting we're running about 50% in acceptance rates. And then we have we developed a new fellowship CSU, which is 6 beds, that is also just started in April. So that's helping us out a lot too, and that's 6 beds. There are strictly 4 state hospital discharges. So again, just to mention again our priorities, what that we would want from a budget priority would be allotting or reallocating the dollars related to DAP and the VHHA pilots. This funding, especially the DAP, is critical to address the bed census crisis. There are currently no additional program DAP dollars for FY 2021 for disbursement to the 5 CSB regions, and this will definitely have an impact on our ability to discharge the folks who are ready for discharge from our facilities. The pilot program funding is also critical, and we've entered into several emergency contracts with private entities, and these dollars are critical to continue these ongoing activities. We would like to request some flexibility on this funding to explore opportunities beyond those that were identified by VHHA. The children's dollars are already allotted. Those were not unallotted, but we are also requesting a modification to the current language to allow for community-based options or beyond inpatient settings, not just inpatient settings, for step-down and diversion opportunities. And this is in line with what the Children's Work Group recommendations, which we'll share in just a few minutes. It follows along with those. Okay. Any questions on the hospital census?
Mr. Chairman.
Is that Delegate Sickles?
Mr. Chairman. Yeah, thanks. Commissioner Lane, could you characterize the improvements that you've made with the private sector hospitals in getting them to, I know in the past couple of years, there's been a little tension between the private hospitals and your hospitals over what their obligations should be. And could you just characterize the improvement or maybe not improvement status?
So I would say that prior to COVID-19, we had met with the majority of the large hospitals and hospital systems, whether it was adult or child and pediatric or child and adolescent, and they were very willing to come to the table and partner, not just for inpatient services, but to develop other continuum of care options and services. And I think that COVID kind of sucker punched us and impacted their financial stability. And so we're now reaching back out, and they're reaching out to us, and we're reaching back out to them if we can get the funding allotted to try to go back down this road and just pick back up and try to partner. And they've been very receptive, and not just having their behavioral health leadership, but their CEOs, their board members coming to meet, and it's been just a whole different feeling to the partnership ability.
Okay.
Thank you. Hey, Mr. Chairman, if it's Monty.
Yeah, Senator Mason.
Thank you, Mr. Chairman. And Commissioner, I too really appreciate the level of detail with the extraordinary barriers list. I think that's great information. Like 45% of them are no willing provider, which is self-explanatory, but 24% of the biggest number is the NGRI process. Can you explain that a little further? As you know, that's a big concern here at Eastern State with such a large percentage of the population being NGRI. Thank you, ma'am.
Yeah. So part of the treatment process for the NGRI population is doing passes out to the community, whether it's and we cut the pass. We had to cut the passes out as COVID struck that were no longer therapeutic. So if they needed to go and look at a potential site for where they were going to live, so that they could make those choices or try it out and then come back, or to do employment or other types of services and things to get the passes so they can earn and move through their treatment. to show that they can maintain their stability while they're on pass, and then they come back voluntarily. So that's part of the treatment process. And also having the services like the psychosocial rehab programs and things like that that have had to, of course, with COVID, have shut down mainly. So those types of activities have slowed down tremendously. And so having to work to get those back in place and get them able to work on those passes going forward. So we do have some concerns around that population. It's not easy to move. So we're really looking for other alternatives, and there are some areas that have tried some alternative things, so we're piloting some things, and hopefully we can get back to offering that PSR and giving the passes at some point under COVID. So that's what I would say is that's the challenge there, is it's part, doing the passes and going through that program is the treatment. It's part of the treatment protocols to be able to be ready for discharge. And COVID's really sucker punched it.
Thank you.
Mr. Chairman. I think he was going to give me permission to speak. Okay. Yes, Commissioner, with when you said that you guys are being like super creative on trying to get people discharged, is a lot of that COVID related specifically, or are these new and creative ways that you're coming up with that can stick even after the pandemic?
So I think it's both. One of the things that we found prior to having all of our outbreaks at our facilities is we went, 4 months, 3 to 4 months solid of really holding COVID at bay in the state facilities, which meant that our population had been there long term, and you could see it wasn't like somebody coming from the community that might want to go into a long-term care and assisted living or a group home. That you didn't know if they had COVID, they may be asymptomatic. We had patients that were ready on the EBL that we had consistent documentation of vital signs and that they were not symptomatic and were not COVID positive. We could do testing to show that. So they actually started wanting, our patients became, something that people wanted because they were having to close and not being able to take admissions, and they were losing revenue. And so our patients became kind of popular there for a while. But now that things are changing in that vein, there also are a lot of things around, for instance, the regulations with CMS around psychotropic medication and the dose reductions that are required for the facilities as they get their star ratings and things like that. And so trying to work to find ways to support them so that they can be successful in maintaining their regulations. And so we're working with VDH and long-term care and assisted living and those types of providers to try to find a way forward. Things like that are going to help us going forward, but also are helping us right now.
Okay, Commissioner Land, if you want to, unless there are other questions, Delegate Price, I apologize. I think I called you Delegate Watts. Unless there are other questions, Commissioner Land, if you just want to continue your presentation.
Sure. We'll move into the CSBs and providers and what COVID-19 has been as an impact on them. So let's start with the CSBs, and the CSB leadership and staff have worked extremely hard to make sure they're still providing all of their code mandated services. This has had a huge impact on the CSBs. They are prioritizing the essential services, including pre-screening, pre-discharge planning, and diversion from inpatient hospitalization at the state hospitals. The state and federal regulation changes allowed them to dramatically increase their use of telehealth, and they were able to pivot and begin using those services. They did an excellent job. But they are still experiencing additional expenses like PPE costs and reduced visit revenue, which has resulted in a reduced capacity for many of the CSBs. About 50% of them have undertaken some level of staff furlough between April and July. Some of those began to lift around mid-June, so that's a positive, but about 25% of the CSBs actually engaged in some level of staff layoff as well. CSB services are going to be required even more as we move through the pandemic, as our folks are increasingly at risk for depression, anxiety, and substance misuse. We also have seen new research that shows that the economic impact of the pandemic may result in an additional 1,720 deaths of despair, which is very concerning. The financial impact is what we want to show you here. They've actually been able to remain financially stable over the last several months, but the way that they've done this is by reducing staff to match the program demand in programs affected by COVID-19 restrictions, like the day programs, and quickly transitioning to telehealth for other programs. So this is actually a good slide, and it shows that they have been able to remain financially stable even under those conditions. They've also had to pivot a bit in how they do the STEP Virginia, the steps that are currently in place and funded, so the same-day access, primary care, and outpatient services. So you can see in some of these, they've done things like they're providing drive-up services, doing telehealth and telephonic-based assessments. Their assessments have had some modifications because some of them were taking 2 hours face-to-face, and now they have to, it's having to make some modifications to that. Let's see, on the primary care screens, they're providing those if the individual presents in person for another reason, and then the metabolic screens are conducted only in person based on a clinical decision that it's urgent. And then other services are being provided by telehealth for the primary screens, like the BMI. And then the outpatient services are consistently being offered via telehealth platforms. Even trainings for staff are being transitioned to virtual trainings, both those that we manage at DBHDS and those that are managed in each region. So DBH Central Office also has done a lot of activity around helping to meet the mental health needs. Our state facility staff have been greatly impacted, and they've really risen to the challenge, but our central office staff has also worked incredibly hard to make sure the system had the guidance, information, and collaboration to ensure Virginians still received the needed services during the pandemic. And we've ensured very active communication with the CSBs and continue to work with them and other HHR agencies around the provision of services. Following the push to identify best practices and resources, we've also been working on safe return to face-to-face settings, both with our staff as well as with the CSBs, and giving guidance for the providers, the licensed providers. We've also looked for non-appropriated funding lines to help support CSBs that are having budget shortfalls. And then finally, I'd say that what were some of the things that we're really proud of are the funding that we've been going after, and we were awarded a $2 million federal grant that was COVID-19 related mental health and substance use disorder services. 80% of that will go directly to services with the specific goals to increase the CSB capacity, help healthcare workers with stress and substance use, and assist those experiencing COVID-19 related mental illness or substance use disorders. The other one that we got, and you may have seen this, I hope you have, we did in April receive a federal grant from FEMA and SAMHSA to help respond to the behavioral health aspects of COVID-19. And what we did was develop a warm line, and it's a COVID-19 warm line, and we call it Virginia COPES. And so what we did was to propose that we would work with Mental Health America of Virginia, and so that's the new warm line. They're providing that. And any Virginian who's struggling during the pandemic can call that warm line and speak to a peer who offer emotional support, active listening, and even referrals to services, so we can get referrals in process. as that volume continues to grow, we're going to also have to partner with others. And so we're partnering with VACSB as the second provider. And we're running that month to month during this emergency response period since April, but we've been approved each month for ongoing funding for it. And then we've just received just under $400,000 that is going to take us all the way through the end of September. And then we've applied for a 9-month grant to be able to run it continuously through next May 31st. And that's just under $1 million. So hopefully we'll get that and be able to keep this, because I know the pandemic is not over yet. So we're going to continue to need to offer that. Wanted to share on the next slide. Okay. Kind of where we're at through all of our licensed providers and the Community Services Board. So we are tracking all of this in a dashboard on our website. So we have a COVID-19 dashboard that keeps up with all of the cases, all of the positive cases, the confirmed cases, and the deaths. And so we've currently licensed approximately 1,100 community providers, and that's for mental health, substance use disorder, and developmental disability services across the state. And so as of end of July, we had 629 positive cases, 55 residential outbreaks reported, and 33 total COVID-19 related deaths. And when we think about how many folks are on the waivers, the DB waivers, it's like 14,000. And then I think there's tens of thousands of folks who are impacted by all the other providers of the services, both at the Community Services Boards and our other licensed providers. Just to put that a little bit in perspective from a numbers situation. So the community delivery system impact. So we are, of course, as I said, tracking the impact on the entire system. So this is where our service is being delivered via telehealth, or where operations are temporarily suspended, tracking changes to capacity, including staffing, and changes to admissions and admission policies, location changes, all of those. We're doing that for all of our licensed providers and the Community Services Boards. So that, and then this is also available on our website. So the most widespread disruptions appear among the day support and residential services. And all of these services, you can see in there where the adjustments, so whether they've implemented telehealth services or suspending operations, you can see a large number had to temporarily suspend operations, both at the CSB and the licensed provider level, the capacity changes to staffing, all of those. And so we're looking at it not just we can also do it by region, and also it's really, I think we've done a good job of making sure that we're tracking everything and communicating and keeping it visible to everybody, and it's on our website if anybody's interested in going out and seeing it, and we keep it up to date. So I also wanted to share an update on the Virginia Behavioral Health System Needs Assessment that JBS International conducted over an 18-month period ending last December. And just before we go into what the findings were, just to let you know what it really was focusing on the key characteristics of the publicly funded behavioral health system in Virginia, the demand for behavioral health services, what our capacity was, how funds are used to support service delivery, what the impact we were seeing from STEP Virginia, the Medicaid expansion, Medicaid managed care, and then feedback from direct service staff and individuals receiving services were actually folded in to give their thoughts on it. And it reached all 40 CSBs and included over 600 interviews, 80 focus groups, surveys, and site visits. So this was a pretty intensive assessment. And so the next slide, Heidi, what you'll see on the key findings are listed there. And so those are those high-level results. The core findings highlight the impact of Medicaid expansion and managed care on the CSBs and a need to adapt and fund STEP Virginia in light of these changes, which have occurred since State Virginia was proposed. For example, from the CSB perspective, the new business acumen, building that business and reimbursement capacity at the CSBs. And that was included to a certain extent, as Mike mentioned, in the pre-COVID biennium budget. So these are the types of key findings that they're having. So the workforce capacity, the funding, needing a strong leadership and collaboration between CSBs and DBHDS, communication, and we've really been working on many of these already. Next slide. So the key recommendations that came out of it, I don't want to go through all of these, but there were really 14, and they're both large scale and smaller scale recommendations. Some will take some time to plan and involve multiple agencies and stakeholders or require additional investments. But there are those that are highlighted, and those are the ones that we're already taking some level of action on. So doing a draft IT plan, supporting workforce development efforts with a development committee, agreeing on a set of performance measures. We've started those discussions. So wanted to share that with you. Next slide. So Sarah went through, so I'm hoping this isn't too redundant, but I did want to share updates on the work groups that Sarah mentioned earlier. And so we'll start out with the medical TDO work group. And that was introduced, the House Bill 1452 was introduced by Delegate Hope and the Senate Bill 738 by Senator Deeds. And the goal, as she said, was to develop the policies and procedures around the issuance of medical TDOs in light of the changes to that part of the statute, which basically clarifies that intoxication qualifies as an underlying condition for which a medical TDO may be issued. And so we've included the stakeholders, as you see there, which include law enforcement, emergency room physicians, CSBs, magistrates. We've actually had 3 meetings and plan to meet a 4th time. And so they've have a draft set of policies and procedures, as well as additional recommendations to facilitate the use of medical TDOs. And so we'll have another meeting and finalize those. So we at least have a draft. That's always a good place to start. On the next one is the TDO Evaluator Work Group, which was the House bill was introduced by Delegate Aird and the Senate bill by Senator Barker. And just to briefly describe it again, is develop a comprehensive plan for expanding who can conduct evaluations for temporary detention orders. And of course, we have representatives from the CSBs, private hospitals, behavioral health advocates, and a ton more, as you can see there. They met for the first time towards the end of June, and they've reviewed pre-screener requirements, the TDO process, and state models from North Carolina, Tennessee, and Oregon. So trying to find out what others are doing and use those to help them decide on which way we're going to go. And then they're going to meet again on the 11th to review those specific models and discuss each strengths and weaknesses. So that's good progress on that one. The bed registry work group, introduced by Delegate Hope and Senator Deeds on the House and Senate side. It's charged with evaluating the current role of the acute psychiatric bed registry and making recommendations for its improvement. They've just started meeting on 7/31. And so their next meeting will be in August, and they'll review and discuss possible specific recommendations at that meeting. The next one is the DAP work group, and it's charged with evaluating discharge assistant planning funds, understanding key areas of spending and their effectiveness, and making recommendations for creating services and housing for individuals leaving state hospitals. They've met 3 times so far, starting with in-depth discussions with DAP managers at CSBs to understand how those funds are being used and broadening to other key stakeholders to help frame the recommendations. So they'll continue to work and making good progress. We only have a few more. The next one is the supported decision-making, which was introduced by Senator Dunavant. The group's charged with understanding how supported decision-making is being used in Virginia, making recommendations for its use as a potentially less restrictive alternative to guardianship. And they've met twice so far, and to talk about how supported decision-making is used in Virginia and other states, and discuss topics such as how to protect the interests of individuals in these agreements and ways to facilitate their use through education and training. So they're making good progress. Their next meeting is in September. It's been already scheduled. The TDO transportation legislation introduced by Delegate Bell on the House side and Senator Hanger on the Senate side. And that's establishing procedures for changing the transportation provider designated to provide transportation to a minor or adult who is the subject of a temporary detention order. And what it's really about is providing that if an alternative transportation provider becomes unable to continue providing transportation, local law enforcement shall take custody and provide transportation to the proper facility. And that actually went into effect on July 1st and allows the transportation providers to be changed mid-transport if needed. And so all of the stakeholders, so the status is all of the stakeholders have been informed, and the CSB pre-screeners, they've already received their training on the new bill. And this information is also being added to the pre-screener certification modules that all pre-screeners have to complete initially to stay certified. So this has been rolled out. So that's good. The next one is problem gambling treatment and support fund. And this was passed during the session. And we're charged with using the fund to provide support to problem gamblers and develop treatment and prevention programs and provide grants to support organizations that can assist folks who have problems with gambling. And we've met with the Virginia Lottery Board to discuss the legislation and considerations for partners, prevention programs, and a lot more. And our next steps will include bringing together a wider group of stakeholders to pull together program plans. And so we're making good progress on that as well. I did want to share, we've talked about the Children's Inpatient Work Group. And so earlier in the year, that group was convened. And it was a group of child-serving stakeholders and wanted to really address the systemic causes for the rising census at CCCA and try to identify solutions for alternative private settings for inpatient psychiatric care. They met in person twice before the pandemic, but then once the pandemic hit, what was decided was they actually did a survey that examined those systemic causes of the high census and what the most effective solutions would be. And so what you can see up there are the key findings, that is the need to invest in comprehensive set of services, not merely additional inpatient beds. And then adolescents that are presenting with acute behavioral aggression, as well as children and adolescents with intellectual or developmental disabilities, they pose a unique challenge to the community private psychiatric hospitals because they have a need for specialized programming and therapies that match the individual's needs and level of functioning. So that makes it harder to get them to accept a patient. And then greater investment in a comprehensive continuum of child and adolescent behavioral health services. So you can see the most highly rated on the survey diversion, so diverting from CCCA versus the step-down solutions. And then on the next page, you'll see kind of going from extremely effective to not effective at all. You'll see that what the work group's ranking of the options were in response to the question, if funding were available to divert children and adolescents from inpatient admission at CCCA, which programs should be prioritized for the funding? So this is the response to that question. And by far the most highly rated solution included access to intensive community-based treatment, including partial hospitalization, intensive outpatient, functional family therapy and multisystemic therapy, and increasing, also on the other end, increasing inpatient bed capacity at private hospitals was rated as the least effective solution. So ultimately, the work group emphasized the need for a full continuum of services to both prevent inpatient admissions and offer viable step-down options. I will mention that DBHDS has also been approached by a private provider who is interested in providing inpatient care for these children, meaning the children at CCCA, or being more directly tied into step-down diversion options, and they may submit a PPEA. So that, more on that if they actually do it.
Commissioner Land, I think it's worth thinking about. You know, the Commonwealth's invested pretty significantly in the hospital VCU has for children out on Brook Avenue or Brook Road. I want to know why we can't treat more of the CCCA kids down there.
So what they say is they can't manage that patient population in that facility. So what we have to do is we have to find a way to allow our partners in the community hospitals to be able to offer the services that are needed for them to be able to accept it. And so that's one of the things that I'm working on, is not just saying let's do an RFP, it's let's talk about what is it what would make it attractive for you to manage this patient population? What do you need to make it safe for those individuals that you're taking in to your facility, but also your staff, and how can we do it at a high quality and get the outcomes that we want safely? So that was what I had, Mr. Chairman, and I'd be happy to take any other questions you or any of the other subcommittee members may have.
This is a very thorough report, Commissioner Land. It's almost like, and you've got some more, I guess, addendums attached with regard to Central State Hospital and other things. But this is very much like drinking from a fire hydrant. I don't know if there are any other questions.
Mr. Chair.
Yes.
This is Rob Bell. Ma'am, this doesn't seem to fit neatly into your presentation, and you may tell me that there's someone else who frankly is better qualified, but anyway, I have a question that you may be able to answer or direct a different way. In the years that we have done this, we've discovered more and more places where the entry into the mental health system is through the schools. This is for the students in the schools. And Albemarle County recently decided that as part of its reopening plan, it would go all virtual but the except for the special needs kids. And the thought being that you're going to try to find a way to provide those services, whether it be the direct counseling or TDT or all the other things we've heard about. Are you aware of whether I'm trying to keep up with what other places are doing. I haven't seen that any other place. And if it's not being done elsewhere, are you aware of any plans or programs to try to ensure that those services get to the kids that would otherwise be, if you will, sort of entering the system through the schools?
So I'm not aware. I was not aware that was the case. I was aware that we were having some either all virtual for the first semester, or there were a couple of schools in Virginia that may be doing a hybrid model with some days virtual and some days in person. But I had not heard that it was all virtual except for the special needs population. Hopefully, if that population can get back to where those services can be offered. But again, that's also a concern that you brought up of what about all the other children who need to have the ability to be assessed and enter the system, and are they going to be able to do that if they're at home and doing school virtually? How are we going to impact that? So that's definitely one of the questions.
Mr. Chair.
Delegate Bell.
And again, maybe you're not the ideal person. In my mind, there's a spectrum of services. Some kids get a little bit of help, and in some, it's the way in which they are identified and then receive significant services. And I know there's even been some court cases about requirements or expectations of the system to provide for special needs kids that have some of these mental health related issues. If you're not the right person, and I'm not trying to make you answer somebody else's questions, is that something that's handled, more through DOE's shop? My image is DOE identifies them, but then you provide the services. That may not be the actual way that it happens.
Right. It's not us that's identifying the kids, but it's a concern of ours. So we're all part of the system, and so I do know who I can get in touch with and maybe get you an answer. So.
Okay, thank you,
Mr. Chairman.
Okay.
Delegate Watts.
Thank you very much, Mr. Chairman. I wanted to circle back. Yes, it's been a fire hose, but one thing that I wanted to know the status of is the budget language that was directed towards the crisis intervention centers being 24/7 capacity throughout the Commonwealth. This is a major issue as we look at justice reform and law enforcement capabilities and support. What is the status of that?
I believe that it's a study group that was required, correct?
That's what the budget language said. Plan to develop additional CIT assessment centers and 24/7 operation. And I wanted to know where we are on that, since there's been significant conversation in law enforcement reform issues.
So I think that's due to be submitted October 1st. And so we would be on track for that.
Okay, but so it is something that you are working on, since it wasn't part of the list that you went through.
Yes, I'm sorry that we did not put that one in there.
Fire hose, thank you.
Okay, are there additional questions?
Mr. Chairman.
Is that Senator Mason?
Chairman.
Delegate Sickles.
That's Sickles.
Yeah.
Yes. One of the, Commissioner Land, one of the things I think that I'm trying to keep my finger on the pulse of is you had in a box on one of your slides, and that is the relationship between DMS, your agency, and MCOs. And having managed care in this population is a little unique. Most states don't do it, it's of angst. DMS really, I think, believes that it's a good thing that we're going back to roots here and looking at, have we been doing it the right way all this time? And now we have a third party in there saying, no, the family or the parents have gotten used to it in the past. And so can you tell us about the progress in that front? You don't have a work, maybe you do, that wasn't mandated by the General Assembly to help us smooth this transition, which we're still in, to managed care.
So I think like when I was speaking about the assessment that we had done, that's one of the things that we've identified to help our CSB partners to learn how to effectively work under the MCO arrangement. And so I think it's all about how do we. It's new authorization processes. It's all new to them, and so it's very hard for them. And we understand that, but we're committed to helping them figure the way through, is what I would say.
Well, so am I. I want to help. I want to figure out what we can do in the General Assembly to help smooth this transition and reduce the tensions and the angst and the finger pointing that's out there right now.
Yes, sir.
That's all. I mean,
okay.
It's a problem. I hear a lot about it and would like to see us make some progress, however it can help.
Okay. Yes,
Commissioner Land, Delegate Price asks, when is the Medicaid Peer Recovery Services report due?
It's a Medicaid. It's a
Yes,
DMAS
Medicaid
report, so I think that Alyssa may be able to talk about that in her presentation, which is up next.
It's up next.
But we can find out. If not, we can find out and get that back.
Okay, thank you.
Yeah.
And I apologize, Dr. Ward. If you want to hit the high points, or you want to go as long as you can, we're drinking from the fire hose today.
Are you ready for me to share my screen, Mr. Chairman?
I am, yes.
Thank you, everybody.
Thank you so much, Commissioner Land.
So can you all confirm that you can see my screen right now?
I can see it.
Excellent. Well, Chairman Deeds, Chairman Bell, members of the committee, thank you for having me here today to report in on behavioral health enhancement, but likewise our current system functioning as it bears consequence on how we move forward with improving quality and access across our behavioral health system. I'm going to be joined today by my partner, Dr. Aplaska, the Chief Clinical Officer at the Department of Behavioral Health, and she is going to be presenting on the portions that discuss the overlap between the STEP Virginia proposal and our behavioral health enhancement proposal. For those of you that I may not have had the pleasure of meeting, my name is Dr. Alyssa Ward, and I am the Behavioral Health Clinical Director at our Department of Medical Assistance Services here in Virginia. So I will hit these very high points, Chairman Deeds, just to give you all kind of the context of the last few months under COVID-19. Our division in behavioral health at DMAS has really focused and worked very hard during this period to do whatever we could to offer provider flexibilities within the federal and state waivers allowed to us to really support the continued delivery of service and access to care for our members across all of our services. So one of the primary mechanisms by which we did that was to allow for unprecedented telehealth allowance across almost all of the behavioral health services, with very small exceptions, including things like the per diem rates for hospitalizations. We also allowed for audio-only services to occur, given what we know about bandwidth issues across internet access in the state, and limits on members having access to the devices that would make synchronous audio-video possible. There were some limitations in our flexibilities, and those included, for example, limiting 1 unit of billing for some of the audio-only delivered services. And we'll get to how we think that may have impacted things in just a moment. We've also had some grace periods allowed around service authorization. We've allowed flexibility around hourly requirements to assure that basically no matter how much you were able to bill for the services under the difficult circumstances, that you could put those bills through. We've allowed for opioid treatment programs to be reimbursed for delivery of medications to the member's location. As well as taking the home dosage of administration. And, a lot of these special flexibilities around our arts program were a reflection of the fact that we're going into COVID, that our overdoses were increasing and that they are, at an all-time high. And so we really wanted to assure that folks were going to be able to receive the medications that they needed. We also allowed for a reimbursement for a maximum of 90 days of pharmaceuticals, including bupe, during this period, and flexibilities around urine drug tests and counseling requirements to assure that we kind of lifted some of the restriction around access to these services. Back to what we have done in terms of telehealth. Now, because we've allowed for this unprecedented amount of telehealth, basically just an open door to telehealth across all of our behavioral health services, this required a lot of collaboration just to understand implications for what this would mean and how to do it well. We worked with the state of Hawaii, who developed this decision tree that you see on the screen. We worked with them to adapt it for Virginia and Virginia's guidance to help providers make decisions about when it would be appropriate to use a telehealth platform versus prioritize face-to-face services. We've participated in a number of cross-state and also cross-sector and cross-Medicaid agency, across state Medicaid agency work groups, as well as working with some of our consultants to assure that we were kind of keeping tabs on how telehealth has been evolving, what platforms have emerged, how other states have lifted these flexibilities, and to be sure that kind of we're keeping pace around the development in telehealth, which I know that many of you have interest in. We've also tried to really be very transparent and communicative with our providers. Our team in behavioral health has been hosting weekly, and then around 3 months into COVID, we went to bi-weekly provider calls that were attended by around 150 to 450 providers each session. This is like a podcast type format where we go through all of the memos as they are released, any resources, any cross collaborations across agencies. We also use this as a forum to share information that is released across our sister agencies to kind of maximize the dissemination of that information. We've also lifted a COVID website at DMAS, and we have a behavioral health section to that website where we load all of the YouTube videos of these provider calls that we do, and the slides where we update our frequently asked questions, have these decision trees. We've had clinical resources uploaded there that have been responsive to the needs of the time, including an updated race-based trauma clinical resource sheet, PPE fact sheets, and connections to other resources. We have also been working within our Support Act grant, which has allowed us to pivot during COVID and use these funds to focus our workforce trainings around the use of telehealth and the delivery of services under these difficult circumstances. So during this time, I just want to give a lot of recognition to our extremely hardworking Support Act staff team, and Ashley Harrell, our senior program advisor in behavioral health over arts. They have held over 70 webinars since April and have reached 3,400 provider participants across Virginia. So just incredible amount of engagement from the providers. This has included, how to engage folks in telehealth for substance use service if you've never done it before, as well as clinical issues relevant to these populations. And excitingly, we've recently been approved by CMS to hold a race-based trauma training specific to helping providers really understand how to drive racial equity through the delivery of access to care, and also understand the issues that they need to be aware of when they're engaging in this work as related to historical and racial trauma. This is just a flyer of some of the work that we have done in these webinars, and these have primarily been led by Paul Brassler and Dr. Mishka Turplin, who I know you all have heard speak before. There's also been a level of incredible collaboration, I have to say, across agencies during this time. Early on in COVID, we worked with DSS, OCS, and DBHDS on a congregate care memo to assure that congregate care providers, being such a risky population, given the transmission of COVID, that we kind of conjointly brought all of the guidance together into a single document for them so that they could understand how it laced together. We've also been working on service recommendations for reopening in partnership with DBHDS, and that has resulted in a letter of recommendations that they put out, I think, the week before last, and it was vetted through the VDH risk mitigation committee. We've also, in response to Delegate Bell's question about educational services and the entry of youth into the mental health system through schools, we have been in discussions with DOE and our sister agencies in how we can support school-based mental health workers in assessing risk in these unusual circumstances where they are separated from their students. We have participated in some town halls together for providers at the CSBs, but we are also planning a town hall with DOE where DBHDS and DMAS will be working together to discuss the services that are available through our agencies and the providers that we contract with, and how schools can partner with them to provide services during this time. We've also been watching carefully the utilization of our school-based services, as those are the most uniquely affected by COVID after schools went out, and I can speak to that in a moment. There was some good news with Executive Order 57 that allowed for temporary licensure for LMHPs. We did see a dramatic increase in the number of LMHPs who registered for this temporary licensure. So the total amount was over 800 LMHPs who registered for those temporary licenses. This is nearly what we see at DHP in like a full year of registration. So this goes back to that question we've come back to as a group many times in our presentations about, we know that we have a workforce shortage around these licensed professionals. Where do we find them? Where are they? Are they here? Are they cross state boundaries? What we have learned tentatively is that there are some untapped resources here. We hope that some of these providers will submit their full package so they can become permanently licensed in the state of Virginia, because this allowance runs out in September for them to carry the temporary license. We're also doing some work at Medicaid to track back and figure out how many of these have become Medicaid providers during this period, or how many of them may be, just operating in more of a private insurance or cash only type of operation at this time. But it was very good news to see this many register. So we were mindful that some of you have questions about what Medicaid behavioral health service utilization has looked like during COVID. So we wanted to give you some high-level looks at the overall trends. And we compared these in this image to what we saw in primary care. So what you can see in primary care is that there was this significant and notorious drop-off in utilization as people were kind of avoiding the doctor's office, not going in for regular checkups, for well checkups and things like that. And so you can see in the blue lines on the left side of the screen where that utilization drops off. Where you see in the yellow, that is an analysis called IBNR. This is incurred but not reported. We do want to caution that this is MCO only estimations for utilization, and these are very tentative. So these are estimates that are used to complete data from the best guess on utilization and cost based on past experience. So they're really like a best guess estimate because these claims haven't all come through yet. On the behavioral health side of this, you can see that the drop off was significantly less. So it decreased by 11% in April, and then only 2% in May, whereas on the primary care side, we saw these very large drop-offs of 39%. And so this is good news, though, because what this tells us is that the pivot to telehealth, which was, a challenge, but achieved by many providers, really allowed them to continue to provide the services even during a time when they were doing less face-to-face delivery. These are our community mental health and rehabilitation services during COVID. If you recall, so this doesn't include those traditional outpatient therapy services, like where you go individually to see an LMHP. This is our services like intensive in-home, TDT, mental health skill building, crisis. What we did see, again, you can see the dip off, but it's not as significant as we saw on the medical side. And this is just a pullout of our substance use services in the arts program during this same period, where you can see that the utilization remained fairly stable. And in fact, you can see that in March and April, there was actually even an uptick in expenditures through the MCOs from the average incurred and from what we were seeing in February. At the current time, because telehealth has been utilized fairly limitedly in the past, not all of the different players at the system have had their systems configured to do proper billing. So a decision we made early on was to not include all of the system changes that would be necessary for us to collect proper data on telehealth, because we didn't want to prohibit anyone from being able to offer access to care by having system glitches or inappropriate denials. And so as of even today, we have kind of given the warning on both the MCO side and on the provider side that they need to begin that readiness, but we haven't kind of given them the flag to say, okay, that you need to have it done by this date. So there have been some that have been configured properly. Maybe they were doing it in another space already for different services, and so some have provided appropriate coding with place of service O2 or modifier GT. And so in doing that, we do have a little window into who is doing proper billing of telehealth. And what we see there is ADHD, attention deficit hyperactivity disorder, is the top diagnostic category receiving telehealth services, followed by opioid disorders, mood disorders, autism spectrum disorders, and then we get down into anxiety disorders, psychosis, adjustment, and then hypertension and ODD. The hypertension is interesting, and it's mixed in there, but it is often comorbid with many behavioral health problems, so not very surprising that we see hypertension up there. The largest telehealth provider numbers that we see so far are actually community service boards who are using the most proper billing for telehealth. And we're seeing a lot of that happen in the traditional psychotherapy space, but also significant increases in billing for TDT, intensive in-home opioid counseling and psychosocial rehab, which traditionally really did not do any telehealth. So overall, high level, we are seeing that behavioral health service utilization has remained relatively stable under these telehealth allowances. This is consistent with other states and national trends. It's good news. It shows that people are finding ways to make it work. We know barriers still exist in terms of members having access to devices, in terms of providers having licenses for synchronous platforms, in terms of broadband issues. But overall, given these broad allowances, people have been able to make it work pretty well. And that's taken a lot of work, and we give them a lot of credit for that. There have been some areas of variability. So I showed you that CMHRS graph that was on the aggregate, showing services have not fallen off in terms of utilization. To Delegate Bell's point, we have seen one service that has been significantly affected during COVID, and that is therapeutic day treatment. Now, of course, we normally see a fall off in the summertime anyway, and we were seeing a lower utilization of TDT going into COVID, but there's kind of a perfect storm around TDT of the MCO management of the service that was resulting in some decreased utilization. Then we saw COVID come through, and we saw some providers that were closing, such as Delegate Bell Region 10, closing their TDT program even before COVID. And so then having COVID come in, schools be dismissed, and it being a school-based, group-based service, it was tricky for providers to figure out how to build that group-based service when we're not bringing groups together to stop transmission of COVID, and when you don't have the schools in operation. And so we are working at DMAS. We have been surveying the behavioral health associations and have been talking with providers nominated by those associations over the last week and trying to think through what other flexibilities or guidance we can put together as these virtual plans are put in place to support TDT programs and figuring out how to make this work, because it just simply won't look like traditional TDT. But in the absence of a state plan amendment, which would be a weighty task that would take too much time to bring anything up into operation next month, what can we do to think about how to do this differently? So we've been starting those conversations more formally to think about what adaptation we can do. We've also looked to see, there's been a lot of discussion in the larger social conversation about the impacts of behavioral health, or the impacts of the pandemic on behavioral health. We've had a lot of concern about that. We've wondered if this was going to create, or at what point it will create, a surge in the need for behavioral health services. We do operate under the assumption or the hypothesis that that surge will come, particularly with the longer people stay in social isolation and the longer the pandemic goes forward. This, accompanied by the social unrest that we have seen, creates a real need in the community for people to access care. We've looked at some indicators of new members in behavioral health, not in terms of newly enrolled Medicaid members, because as you know, we've seen many new enrollments during this period, but folks who are just initiating behavioral health services. So we can look at assessment data for new patients to see whether we see new members coming in. We're not seeing a surge at this time, but we are continuing to watch that to see where those needs grow, as well as monitoring all of this utilization. So that is my summary of our kind of current status in the system during the pandemic. And now I'm going to speak to the proposal for enhancement of our behavioral health system. On the agenda, I believe this is still referred to as redesign. If you recall, redesign and enhancement are one and the same, and the new name is enhancement. And as Mike Tweedy nicely articulated in that opening part of the agenda, these are funds that have been unallotted.
Hold on a second, Dr. Ward, if you don't mind. Does anybody have any questions about the first part of her presentation?
Mm-hmm.
Okay, I apologize, Dr. Ward. Go ahead.
My pleasure. And we can always follow up as well if people have them afterward. So this proposal is currently unallotted, and the governor, of course, is having to make very difficult decisions in our budgetary circumstance with the fate of this proposal in the context of all of the other many important proposals that Mr. Tweedy highlighted in his introduction. To remind you, and for the new members of the committee who may be less familiar with the enhancement proposal, this is something that was brought forward as a cross-agency proposal from DBHDS and DMAS, which is focused on implementing a fully integrated behavioral health service continuum for Medicaid members. This comprehensive system is intended to improve the quality of services, to integrate evidence-based care in a way that's reflected in rates, and so reinforces and sustains that evidence-based care in the system, that adopts a trauma-informed lens, and that is cost-effective and protective of what are, as ever, precious public funds for the delivery of these services. Dr. Plaska and I are going to share the mic a bit at this point to talk a little bit about the history of this and where we are at today. Just as a brief overview, we have always talked about behavioral health enhancement as kind of the big hug that goes around all of the other incredible work that has come before us in trying to work towards improving the system, which includes many of those other initiatives summarized today and much of the work of this committee. So this is really intended to bring on rates in the Medicaid system for the services that we know have been shown to work. And it is meant to support and tie together the efforts, for example, of the Family First Prevention Services Act through the Department of Social Services, and to provide Medicaid rates for the services that they would be bringing online through 4E dollars. And just basically assuring that there's alignment across the types of services that are available that are high quality across the system, because these are overlapping populations. A lot of the kids that are at risk for foster care are children who are Medicaid members. And obviously, almost all the children who are in foster care are Medicaid members. And in terms of the juvenile justice population, almost 60% of the kids in their service system are Medicaid members, and they receive some of the services we're proposing. So it's really about bringing alignment across the state and ensuring that we're all delivering the same high quality services and have appropriate rates set for those across all the different payers. And so Dr. Plaska is going to speak a little bit about the STEP Virginia initiative and how behavioral health enhancement and STEP Virginia were intended to really tie together to address the system needs that were actually summarized very well in the inpatient work group recommendations that Ms. Land spoke of before, around really driving community-based care and ensuring that we have a continuum to serve folks so they can come out of the hospital. So Dr. Plaska, take it away.
Sure, thank you, Mr. Chairman, members of the subcommittee. My name is Dr. Plaska. I'm the Chief Clinical Officer for DBHDS, and I serve as the agency lead on behavioral health enhancement with Dr. Ward as my partner at DMAS. So this slide is really to highlight the relationship between behavioral health enhancement and STEP VA, which are really kind of the monumental integral pieces for transforming our community behavioral health system and the long-term answer to our critical issues related to census. So STEP Virginia there at the bottom is has provided a pathway for creating mental health system reform in the 21st century based off a national SAMHSA model, which is improving access, quality, and consistency and accountability. And STEP Virginia, which of course is implemented across Virginia's public behavioral health system or community services boards, who are the safety net of mental health services here in the Commonwealth. And so for any well-functioning behavioral health system, a lot of that safety net provider and a lot of the strengths really lie in that system. And so STEP Virginia and the CSBs serve approximately 200,000 people, and 50% of those individuals are Medicaid members. And the other 50% are individuals with no insurance, no way to pay for services, individuals in transition, such as just stepping down from hospitalization or incarceration, and really can't access services in any other way. And so what STEP Virginia does is ensures that those 40 CSBs provide consistent access to 9 core service categories, regardless of their location or payer source. So it really elevates the bar and levels the playing field so that those services within those 9 distinct steps, or those categories of those 9 distinct steps, actually encompass 1 or more types of services. So those services exist as pillars of the system rather than a continuum. And those implementation timeline for those service categories have been already defined, and that implementation timeframe is in code. And the mandates specify that services be accessible, but does not reform the services themselves. And so where enhancement comes in is that the population that enhancement eventually reaches or has availability of reach to is the 1.4 million people served through Medicaid who need behavioral health services. And based on now a few years old data, but approximately a third of Medicaid members have a behavioral health diagnosis that needs treatment. So around 390,000 individuals under Medicaid will need behavioral health services. And if you think about it, 100,000 of those are served through the CSB. So that's a really high proportion of those individuals that access care that way. And the providers that enhancement involves are both public and private providers who accept Medicaid. And so that interface between our public system and our private system really provides the framework for the entire system of care. And those will have rates established or refreshed for behavioral health services across all levels of care to ensure that the rates are sustainable for the provision of high quality services. So I'm sure that you've heard from a lot of the workforce about the mental health rates and how they may not be reflective of the care and time and expertise that is provided and the importance of that work. And so this is also enables us to look at them. And enhancement, which is in contrast to STEP Virginia, are in a comprehensive continuum. And so those proposals are grouped together based on Virginia's priorities. And so what we have on the next slide is what we've proposed as a multi-phase approach to a whole continuum of services to look at 6 critical services that address the inpatient bed crisis, as well as help us move towards that North Star of building out an entire continuum of care. So these services currently exist here in Virginia and are licensed. So they're not new to Virginia and the Commonwealth, but they are either not covered or adequately funded by Medicaid. So for example, what we have here in the first column of buckets is partial hospitalization programs and intensive outpatient programs. These are high intensity, highly structured, facility-based programs that serve as step down to inpatient hospitalization. So you get all of the day program that you would receive in an inpatient care, but at the end of the day, you would go home. So you're not taking up a bed in the hospital. And these are programs that exist in Medicaid for their Arch program and has been shown to draw down costly ER visits and inpatient hospitalizations. So the workforce exists, the program exists, but they don't actually have a rate on the mental health side. So they're only for that substance use population in Medicaid and not on the mental health side. And there are private providers of PHP and IOP in Virginia. And then I'm going to skip to the last column of buckets, which is multisystemic therapy and functional family therapy. These are evidence-based practices for high-risk youth, which have been made available through the Department of Juvenile Justice transformation, but they don't have a Medicaid rate. And so DJJ has effectively, by implementing evidence-based services, decreased the number of beds and closing down juvenile correctional facilities from over 600 beds in their system to around 200 beds in their system in about a year by implementing services such as MSP and FFT, along with an array of a whole package that they've done to be able to do this. But in the Medicaid space, MST and FFT don't have a rate. So DJJ pays a case-based rate. And this really creates access and equity issues for Virginia's kids, where they actually need to be DJJ involved to receive these high quality services. And a lot of the kids, which are hard to treat, hard to place, would benefit from the service, such as those who are placed at the Commonwealth Center or in residential treatment centers across Virginia. PACT, or Program of Assertive Community Treatment. This again also exists in Virginia, but is not reimbursed at a rate that covers the whole service. And so this is what is called a hospital without walls. So the intensity of this program really allows people to live in integrated settings in the community outside of hospitals for people with serious mental illness. But the rate that we have in the Medicaid space limits the ability to adhere to those fidelity standards of that program. And also it's not available at every CSB. So it's widely available, but in order to expand it statewide, we would need to blend that funding with some Medicaid dollars as well. Again, this would be individuals who are often served, who are coming out of state hospitals or need services from the extraordinary barriers list. And then lastly, comprehensive crisis, which is sort of a continuum of itself, brings on Medicaid rates for services recommended through the crisis work groups of STEP Virginia, and ensures that those reimbursements are appropriate and draw down a federal match for members who participate in crisis care. So comprehensive crisis, when we use that term, really talks about everything, including a mobile crisis response, community-based crisis stabilization units, and 23-hour beds. So there's an array of services there that are interconnected, and without all of those pieces there, would present a different crisis. And so having a comprehensive crisis system really draws people out of emergency rooms, decreases the involvement of law enforcement in the response to a mental health crisis, and allows people to remain in the communities and be served in the communities in which they live. The next slide is just talking about how these services have been functioning during COVID. And so we've heard a lot of changes and service modifications due to COVID. And so we've seen that too with our MST and FFT providers, and they've been able to shift to a combination of telehealth and face-to-face interventions with continued positive outcomes. The number of teams have continued to grow in Virginia. The families have remained engaged in treatment. PAC programs are continuing to deliver service and have not seen a reduction in attendance. And some programs have experienced growth, and we've actually added an additional PAC program out in Mount Rogers. So despite COVID, we have a lot of those evidence-based practices that are sustainable and highly structured. Partial hospitalization and intensive outpatient programs have continued to provide services, also with a combination of telehealth and face-to-face treatment. And as Dr. Ward had illustrated earlier, those referrals have increased to outpatient mental health providers due to individuals choosing the least restrictive care of what's available. We know that comprehensive crisis services continue to be a need to reduce unnecessary hospitalization, also reflecting back on Commissioner Land's presentation about where our census has been. And even the crisis services have been able to be delivered through telehealth services when it's clinically appropriate. So our CSVs have really done a great job in being able to do that and respond to crisis effectively in that manner.
So one of the big messages with all of this is that we have really, throughout COVID, have tried to keep track of how these services that are currently being paid by other funders and are operating, rather limitedly in Virginia. We wanted to assure that they were still alive and surviving in COVID, so that should we be reallotted these funds, that base that we counted on and being there to grow off of for enhancement was still there. And so this is all good news to say that it's all still there. And these are all services that have continued to find ways to work and actually have data around them working even under expanded telehealth. And so the base to grow off of does remain. Now, this next slide provides just a quick overview of the unallotted funds as a reminder that the implementation of these services was intended to be over the biennium with multi-systemic therapy, functional family therapy, and the program of assertive community treatment rates coming online in this first fiscal year. And obviously that has been unallotted, but these were intended to kind of stitch together with other implementation timelines like the Family First implementation. And then all of the services, the remaining services, comprehensive crisis, partial hospitalization, and intensive outpatient were to come online 6 months later in January of 2022, right? So that's correct, January 2022. So then Dr. Plasko is going to summarize the unallotment of the companion workforce development dollars that had originally been allotted to DBHDS.
So this next slide is just really reflecting that the workforce needs preparation for the changes related to behavioral health enhancement. And so it provided $1 million in general funds in FY21 and $1.2 million in FY22 to conduct a behavioral health workforce study and create infrastructure for those evidence-based practices in behavioral health. So really intended to support our behavioral health providers and bring them along with us with these changes, which we realize are significant, and help them either prepare the type of training and information and billing support that they would need to implement that. There is also a language only to align DBHDS licensing with the Medicaid behavioral health services. It had funding associated with it, but this permitted DBHDS to promulgate emergency regulations related to the licensing of services impacted by behavioral health enhancement, which was introduced in the budget. And so this is something we have moved forward with. So in the event that it is re-allotted, that licensing does not present a barrier to bringing these services online. So we have that process moving forward still.
So to close out, we're just going to give a high-level overview of what the initial implementation plan had been for this proposal, and then speak a bit about how we have kind of kept the flame alive during COVID, what we have done to assure that should this be re-allotted and the priority be there, that we are ready to take that flame and keep it growing. And so The initial idea had been, if authority was granted to proceed, that we would bring together the hundreds of stakeholders that we worked on this process with, that we would begin planning with them for the implementation, including the system changes and the workforce training and firming up the medical necessity criteria, and kind of being very transparent with them about the whole process of bringing them live into the system. There's all of that work that would go on internal at Medigate in terms of our state plan amendments, changes in our regulations and manual, and then in companion with the DBHDS side, that workforce training and planning for workforce training, a development of metrics and accountability for parties like yourselves and our members and stakeholders to be able to show that this is truly an enhancement, that these services would help us achieve the outcomes we're looking for our members and improving lives. And this would all lead up to the hopeful application for the 1115 SMI waiver that would bring down those federal dollars to allow for residential care for adults. And so we've had to make some revision, obviously, under the circumstances. One thing, given the state of the world and our desire to be engaged in that state of the world, we desire to start an additional work group should we move forward that would be focused exclusively on racial equity and assuring that we're using racial equity toolkits to look at things like disaggregated data for the outcomes of enhancement, for looking at equity in provider availability of services and access to services across different demographics. And we would propose that we would add this to some of the many different thematic work groups that we had in planning for the implementation. There was a General Assembly mandated Behavioral Health Enhancement Advisory Council composed of the behavioral health associations, and we actually have already initiated that work group just to discuss the status of the proposal and to await the fate of the proposal, and have met with them one time and meet with them again next week for the second meeting. So other things that we have done is we've continued some cross-agency work around the development of an evidence-based practice center that would support the cross-agency efforts at driving evidence-based care across Virginia and doing that with academic partnerships, looking to help with cross-workforce credentialing for all of these types of new types of services. We have also looked at alternatives in funding, such as health services initiatives projects at DMAS to support enhancing services with different types of funds. They couldn't do what the initial intended proposal seeks to do, but these are some types of funds that Medicaid has not availed itself of in the past that could support behavioral health services in general and some workforce training. So we've looked into those and started to we joined an initiative to learn about how we might be able to use those. We have also continued with installation planning despite the unallotment. So we've worked many hours in companion with our MCOs on solidifying medical necessity criteria for these services. We've also submitted preliminary drafts of state plans to CMS to do this check-in where you say, like, how does this look? Does this look like something that you all would accept? And those have gone very well. We've had training brainstorms cross-agency to think about how we could pivot, what workforce training would be needed. And of course, we started that advisory meeting to hear the concern of the associations about the current climate and should this move forward, what would their advisement be about any change in plans or considerations. We've done a ton of work, to be honest with you, on the outcomes and metrics piece at Medicaid. We received a serious mental illness innovation accelerator program from CMS and have been participating in that during COVID. We've developed really unique dashboards where we're going to be able to pull cross-agency data to look at all of the different metrics that affect the serious mental illness population. These are the folks that are using those state hospitals. These are the folks that we're trying to find more community-based solutions for, and these types of dashboards would allow us to visualize the needs of that population and to track their needs over time. We've also developed a template and an initial dashboard for our CMHRS services, which has taken quite a bit of effort, but we have it. We've been testing it in the last 2 weeks. This will also allow for more better public-facing data on service utilization and outcomes that we can translate and have those templates ready for enhanced services if they were unallotted, so that from the beginning, we would have a way to have report out on how the services were functioning and their outcomes. And we've, of course, started the report that will be required for the 1115 SMI waiver as part of that process. So this is all the steps that we have taken so far to really keep that candle alive and hold out hope that, that this will, we know there's many competing priorities. We know this is a very difficult time, but we know it's our duty to assure that, we still keep working towards the improvement of this system for those that really brought us into this work and those we care about. So we've kept going. We know that there's not a lot of time today, but this is our email box. I'm also, of course, happy to provide you with mine, but this is where we've been taking all of our questions about enhancement and our COVID-19 response within behavioral health. And Dr. Plaska, I'm sure we're happy to answer any questions you may have today.
Thank you very much. I remember last year when we still called this redesign, we were really interested in the intensive outpatient program and the partial hospitalization because we thought, everything fits together. We thought this would help us with the census issues. And I'm sorry about the unallotment, but it is what it is, I guess. Are there any questions or can people just email? Okay, thank you, Dr. Ward and Dr. Plaska. Thanks very much.
Thank you. And that is the same email for DBHDS as well. It's a shared mailbox.
Delegate Price, do you have a question?
Yeah, Mr. Chairman, if I may.
You may.
Awesome. I just wanted to make sure, because I know that we've talked about the monetary parts for the budget and all of the decisions that we'll have to make on that. But are there any legislative needs that you all have that could help you all as you go about your work? And this is for Dr. Commissioner Land as well. Any legislative needs to help you continue to make these services stable in the face of COVID, knowing that, that second wave might come and we're only going to be in special session once, before January. But were there any statutory obstacles from you all that, being able to do great work that we would need to act on for special session outside of the monetary stuff?
I'm pausing for the commissioner.
I'm trying to think if there's anything else. I know that we've asked for some language changes that are not really funding related, and we've of course we don't know. Everybody has sent up priorities that we'd like to ask for up through HHR and to the administration, but every agency wants something, and so not everybody's going to get something. Or all that they want, so we're not real sure. So we're not really able to share those at this point, I don't think, if they haven't been approved as to move forward, would be my concern. But there are some more policy type things.
Chairman Deeds, Delegate, I've heard that there is quite an appetite for permanency in the telehealth delivery, since the current telehealth flexibilities are just allowed through the federal waiver right now. And we start letting go too. If you can't hear me, I'm getting an internet instability message. But DMAS has been working towards that effort of permanency, and really trying to draw up a proposal around what that would look like. So I know that there's a lot of appetite there. I think it's okay for me to say that that's been a real focus of our work, and led by Dr. Bacciaretti, our Chief Medical Officer, and in collaboration with my division, as we have the special expertise in the behavioral health services. So I do think that is a nationwide trend of moving towards permanency, and it sounds like it's going to be done at the federal level as well, from what I've heard.
I'm not sure that we're going to have a permanent one, but several members have introduce language or talk to the speaker about this issue. And so she asked me to put it all together. I don't know what that means yet, because she's the one who's collected everybody's legislative ideas. But hopefully we'll have one bill that comes out on this subject, and or budget language or legislation, one of the two.
Delegate Sickles, Chairman Deeds, I think there's a lot that goes with it. I know that you all appreciate that. So there's, the allowance from the Medicaid state plan to be able to do it, but there's the other piece, which is the broadband capacity, which is that real thing that we can't do anything from where we sit.
Well, we're working on that too.
I think that's going to be a real linchpin in assuring that people can actually participate in the services. And I think that also speaks to, go ahead.
I promise you there's going to be more money for that. There's going to be more money for broadband, because it's something that we can do with one-time money, which we may have some, and there's a big worry about recurring expenses, but broadband is something that we can do and invest in, with one-time money. So everybody's aware of that. The education situation is really putting a premium on having with our kids having access to it. So I'm sure the governor's proposal will include that, and we may add some, who knows. But also, you can draft your own bill and let us know. Go through your system and get a bill drafted up, and we'll find somebody to introduce it. You're not a potted plant.
Okay. Are there additional questions for Dr. Ward or Dr. Oplaska? If not, let's move on to the next two things on the agenda. Thank you very much, Dr. Ward. Thank you, Dr. Oplaska. The next two things on the docket are legislation referred to the Joint Subcommittee, which in this past session, and then a discussion of the 2020 work plan. I wonder, Sarah, if you've already talked about the bills that have been referred to the Joint Subcommittee.
Thank you, Senator Deeds. I've talked about most of them. There were a couple more that were referred. The list has been distributed to the members, and I'll include that on our study website tomorrow. So there's no need to walk through them right now unless you have questions.
Okay. In terms of a work plan, we've got a very abbreviated year. I don't recall in the past we waited till August for our first meeting. What I'd like to do, in the past we've worked from work groups. I think that we ought to continue a structure and financing work group that looks at some big picture issues with respect to what our system ought to look like, what our relationship between the hospitals and the CSBs ought to look like, what our relationship between the department and the CSBs ought to be, and how we pay for it. There's a significant junction between criminal justice and behavioral health. We've had a work group in the past on that. We ought to continue that work. We've still got an awful lot of work to do there. And it's clear, especially from the bills that have been referred to us, that we need to think about crisis intervention. We need to think about the TDO ECO process. We need to think about MOT and come up with some solid recommendations on that. So I'm thinking there will be 3 work groups. And what I'd like you to do is within the next week or 10 days, get in touch with Sarah or with me and let me know which work group you want to serve, what your interest is. And what I think is that, as I said in the beginning, I expect us to be able to come up with concrete proposals. We are in a tough economic time, but people's lives are at stake. Our work is important. It matters to people. So I'd like for the work groups, once they're put together, to be able to come together probably monthly through the end of the year. Maybe the commission itself, the full group doesn't have to come together more than once or twice more this year to look at recommendations. I think, as Sarah said in the beginning, this commission is getting ready to expire. So we have kind of 4 options there that we probably ought to think about as a whole, as an entire commission. Do we let it expire? Do we extend it again? Do we fold the work into some other existing entity, such as the Commission on Healthcare? Or do we create a permanent commission on behavioral health, on mental health? We have 4 options, it seems to me, that we need to come up with a clear recommendation by the end of the year. But that's just what I'm thinking, and certainly anybody else's ideas ought to come into play. So please, what do you think?
Mr. Chair.
Delegate Bell.
So in the past, you've kind of created the subcommittees or subpanels based on the workload rather than trying to have 2 carefully assigned topics. In other words, like we'd have a year that we didn't have much in a certain area and a whole lot in the next. Would it be appropriate to have you or Sarah kind of come up with a list of what each one will look at, and then people can say what they want to do, or would you rather do it by top?
Well,
you don't have it where you have 14 things for one of them and only 2 for the other one.
Well, I think you're correct there. Sarah's got a list of topics for 2020 that's included in the stuff that was sent out to everybody. So those are some of the questions we're going to be looking at this year. The bills, it looks to me like, that have been referred to us will fold pretty easily into one of the 3 work groups. So it seems to me that each of the work groups is going to have plenty to do. It's not like one of the work groups is going to have less to do than the others. They've all got substantive things they've got to focus on this year.
Thank you.
Okay. Well, then I would appreciate it if you would think about look over this stuff on the bills, look over the topics, see if there are other things you think we ought to be addressing, because by no means is this the exclusive list. Though it looks like the House of Delegates in particular has set us an awful lot of work for this coming year. And the number of referred bills is significant. Thank you very much, Mr. Chairman. It's significant. So we have to take a look at these issues. There may be other things that you all won't want to consider, but within the next week or so, if you could be in touch with me or be in touch with Sarah to let us know which work groups you want to serve on. Let's get this thing started and maybe have a goal of during the special session. So by the time we conclude the special session, we have a work plan schedule. We kind of we can figure out what the work groups are going to be. We can lay out a plan for the work group meetings to occur. We can coordinate those work group meetings so that at least once or twice more this year, we can do work groups in the morning and full commission in the afternoon. Maybe we'll be at a spot where we can actually all be in one place before the end of the year. Maybe not. Maybe we'll continue to meet this way. If that's the case, we can figure out how to get back together. But does that sound like a plan? Does that sound like, does anybody have other ideas?
Wait, Mr. Chairman.
Senator Mason.
Would you, Sarah, would you send out the 3 working groups and kind of the outlines that he just walked through? So as we look at the bills, we can determine where it goes. Thank you. And Mr. Chairman, you outlined 4 directions for the commission. I don't think expiring and ending it is one. So I would suggest that it should be only 3.
Well, we ought to be thinking about this. I mean, we ought to be thinking about where we go. I think I've shared this with several of you that in 2014, after the first House Joint Resolution or Senate Joint Resolution passed creating this work group, Richard Bonney said to me, I'm glad that you've got this going. I'm glad that it's 4 years, but you've got to understand the work will go on. So the work will continue. And, I've found we've been at it now more than 6 years. And the work it's still out there. There's still as much to do or more to do than there has been accomplished. So that's why we have to all be dedicated to getting as much done. We have to act with urgency, it seems to me, in terms of facing our workload.
Mr. Chairman.
Mr. Chairman.
Delegate Sickles.
Mr. Chairman, yes. I would, at the end of this year, when we've done that, when we're finished with, not finished, but have a status report on everything we're working on, if we could just get a short summary of that. And so when we go into the next session, I can limit the number of studies that we send and work groups we can send over here, and also tell folks, hey, we're working on that. To be honest, I didn't know exactly what your agenda was this year when we were sending all that stuff to you. So I think I'll have a better understanding of the capacity of the Deeds Commission and what we're working on now, and possibly limiting, what we send over here next winter.
Thank you very much.
Mr. Chairman,
Delegate Watts.
I was just going to follow up on Senator Mason's comment, even though you told us to wait until December to talk about this. While the sense of urgency that you expressed is absolutely a must do because of the issues out there, I think what this 6 years has underscored is that we have very specific problems within behavioral and mental health that must be addressed, and they get lost when they're blended into general health care. And so that I have to reiterate what I've said before, this should be an ongoing separate commission.
Well, we'll have time to work all that out. And my guess is we'll do it closer to the end of the year. But certainly before the bill deadline, so we can get it drafted. There are limits on the number of bills we can request this time, request to get drafted. So certainly I don't want to be Scott Servell, and I've never thought that I could be Scott Servell if I wanted to be. But in the past year or two, I've ended up making a lot of requests for this commission. So this year, I would certainly, because we're limited in the number of bills we can request, I hope we can allot those requests among all of us so we can get the bills drafted. Okay, is there anybody else that has anything good for the order? For the good of the order? Well, then, we're adjourned.
Thank you, Mr. Chairman.
Thank you.
Thank you, Mr. Chairman.
Thank you.